We are joined today by 6 postgraduate pathology students from different medical colleges across India, who will be in this sign today's live seminar.
Is my screen visible and am I audible?
Yes, ma'am. Yes, ma'am.
Okay, so we'll start with the slide seminar for coagulation disorders. So starting with the basics, some of this was already covered by my colleague in the previous session, but just to revise. So what are the screening tests for hemostasis? So can anyone tell me what are the screening tests for primary hemostasis?
Platelet count, bleeding time.
Yes, very good. Yes, so platelet count and bleeding time. But again, to revise, bleeding time is a screening test only to be done in a patient who is presenting with history of bleeding, but it is not a good preoperative screening test. So when a patient presents with a definite history of bleeding, you can do bleeding time as a screening test for primary hemostasis. And what are the screening tests for secondary hemostasis?
Prothrombin time, APTT.
Very good. Yes, very good. So it's prothrombin time, which screens for the extrinsic and common pathway, and the APTT, which screens for the intrinsic and common pathway. But which is the most important screening test? It is
History.
Yes, very good. History is the most important screening test. It is the key to understanding and diagnosing hemorrhagic. Without any symptoms, an abnormal coagulation test result has no value. But with a good history, you just need some basic investigations in the lab to arrive at the diagnosis. So bleeding results. Yeah, sorry, any questions? The bleeding results from failure of any part of process. Can I request everyone to mute your mics unless you have a question or if you want to answer? Okay. Okay. So bleeding results from failure of any part of the process leading to a stable clot, and the resulting bleeding manifestations will vary depending upon the severity of extent of deficiency will determine the severity of bleeding and which phase is defective, whether it's a primary hemostatic defect or secondary hemostatic defect will determine the site of bleeding. So for example, if the patient gives history of mucocutaneous bleeds like epistaxis, gum bleeds, urinary tract bleeds, GI bleeds or menorrhagia, or superficial cutaneous bleeds like petechiae, purpura, ecchymosis, small superficial subcutaneous hematomas or easy bruisability. So if the only history that you're getting is superficial mucocutaneous bleeds, then you're most likely dealing with a primary hemostatic disorder. This means that there is a defect in formation of the primary hemostatic plug. And the primary hemostatic plug is formed by von Willebrand factor and the platelets. So either it could be a von Willebrand disease or we are perhaps dealing with a platelet thrombocytopenia. Is this clear? Yeah. On the other hand, if suppose the patient gives history of deep bleeds like bleeding inside the muscles or joints like muscle hematomas as you see here, which is a calf muscle with a huge hematoma or hemarthrosis, sometimes even resulting in fixed flexion deformities, you are dealing with a secondary hemostatic defect, and the coagulation factors help for secondary hemostasis. You're dealing with a coagulation factor deficiency. Now, how do you know the severity of bleeding? A mild bleeding disorder is one in which there is infrequent symptoms of bleeding, history of bleeding only upon provocation by trauma or surgery, or only mild episodes of mucocutaneous bleeds. On the other hand, a severe bleeding disorder is one where the bleeding is more frequent, spontaneous, even without a significant provocation, prolonged extensive bleeding. In a developing country, even a single episode requiring hospital visit can be considered as a severe bleeding disorder, and any bleeding episode requiring surgical hemostasis or blood transfusion. So, in order to improve the collection and reproducibility of bleeding history, the International Society of Thrombosis and Hemostasis has developed the bleeding assessment tool, wherein 14 different symptoms are assessed and a score from 0 to 4 is given to each of these 14 symptoms. So just to give you an example, for example, looking at this particular symptom epistaxis, so a score of 0 would usually mean that that symptom is absent or trivial. A score of 1 would usually mean that that symptom is just present. A score of 2 would mean that that symptom required consultation. A score of 3 would mean that it required some sort of surgical hemostasis, and a score of 4 would usually mean that it required blood transfusion. So the total score is then calculated, and a total score of 3 or more than 3 in children, 4 or more than 4 in adult males, and 6 or more than 6 in adult females is significant to identify a bleeder. When I say adult female, it means a female who has attained menarche. So this is a study done to assess the utility of BAT score, and we can see that it is extremely useful to differentiate a non-bleeder from a bleeder. It is important to look at the age of onset. For example, if the patient has a history of bleeding since early childhood, it is most likely inherited, whereas if there is history of onset of bleeding only late, it is acquired. Family history. If there is history of males on the maternal side being affected, like maternal grandfather, maternal uncles, or maternal cousins, you're likely dealing with an X-linked recessive. And hemophilia A or B are the only two X-linked recessive inherited bleeding disorders. Von Willebrand disease, with the exception of type 3, may be inherited in an autosomal dominant fashion. So you may have history of a member in each generation of the family being affected. And all the other inherited bleeding disorders are autosomal recessive. So in such a case, parents will be asymptomatic carriers, and there may be history of the patient being born of consanguineous marriage. So now we go to the cases with this background. So now for each of these cases, I want you to calculate the BAT score. And based on that, you have to tell me whether the patient is a bleeder or non-bleeder, severe or mild, whether it's a primary hemostatic defect or a secondary hemostatic defect, whether it's inherited or acquired. If inherited, what is the mode of inheritance? And finally, what is the likely diagnosis? Okay, so we start with patient A. So this is a 12-year-old boy who presented with history of spontaneous large swelling at the back of the calf with discoloration. As you see here, there is a large muscle hematoma in the back of the calf. He's been symptomatic since 2 years of age. He has knee joint swellings, and he now walks with a limp, and he requires factor concentrates. There's history of epistaxis requiring hospital visit. Family history: the maternal uncle died of hemorrhage after road traffic accident, and mother's sister's son, that is maternal cousin brother, also has history of bleeding. So now let us calculate the BAT score. So Sherin, can you tell me what is the BAT score here? The patient has muscle hematoma.
Yes, ma'am. The patient has a spontaneous muscle hematoma at the back of the calf, so that will go to a 0.3, which because it was spontaneous and it required therapy.
So if you go back to the history, the muscle hematoma, the patient was not receiving factor concentrate for muscle hematoma. So muscle hematoma was there, which was spontaneous. So that gives us a score of 2.
Score of 2. And plus
yes.
he had a knee joint swelling, and for this he was walking with a limp and received factor concentrates. So
Yes.
this will amount to a score of 3.
Yes, very good.
And then he had an episode of epistaxis, which required hospital visit. So that will go to a score of 2.
Very good. So what is
his
our total
score is 7.
Very good. Yes. So now these questions are open for all. All of you can tell me whether this is bleeder or non-bleeder.
He's a bleeder because it was a spontaneous bleeding.
Mild or severe?
Severe, because the bad score is more than 3.
Yes, not because of the bad score. The bad score will not tell us the severity, but if you look at the patient's history, the patient concentrate support, he has required multiple hospital visits, so it's a severe bleeding disorder. Primary hemostatic defect or secondary hemostatic defect?
It is mostly a secondary hemostatic defect because of large hematomas, intramuscular, and both joint swelling.
Yes, very good. So because there is muscle hematomas and joint bleeds, it's a secondary hemostatic defect. Inherited or acquired?
It is inherited because he has a history of maternal uncle and maternal cousin being affected by the bleeding disorder.
Yes. So there is a definite family history, and even the patient is bleeding since very early childhood. So it's inherited. And what is the mode of inheritance?
X-linked.
Yes, X-linked recessive. So what is your possible diagnosis?
Hemophilia.
A or
Hemophilia?
A or B.
Very correct. It could be A or B. So based on the history alone, you have almost narrowed down to the diagnosis, and you know that you're either dealing with hemophilia A or hemophilia B. So history is a very good screening test. So let us look at the patient's results. The platelet count is normal. The PT is 10.5 seconds, which is normal within the reference range. The APTT is 92 seconds, which is prolonged. So what is the next step that you want to do?
Mixing studies.
Yes, very good. So next step will be the mixing studies. And suppose the mixing studies show correction, you know that you are dealing with a factor deficiency. So deficiency of which factors would result in isolated prolongation of APTT?
8, 9, and 11.
8,
11.
intrinsic
9, 11, 11 and 12.
Yeah, can you repeat?
8, 9, and 11.
11 and 12.
Yeah, 8, 9, 11 or
12.
12. Yes. So if you look at the pathway here, you can see that it is either 8, 9, 11 or 12, which could have caused isolated prolongation of APTT. But we know that patient with factor 12 deficiency will never bleed. Patient with factor 11 deficiency will have a variable bleeding symptom, wherein the patients will bleed only upon provocation like surgery or trauma. And so here we know that we are either dealing with 8 deficiency or 9 deficiency.
9 deficiency.
Very good. Very good. So as Shereen already told me, what next if the results are prolonged? So you do the mixing studies. So yes. So how do you perform the mixing studies? You mix equal quantities of patient's plasma with pool normal plasma, and you repeat the same test which was prolonged. So in this case, because the APTT is prolonged, you repeat the APTT on mixing studies. So what is the rationale of performing mixing studies? Suppose on performing the mixing studies, if you get a correction, you know that the factor which is deficient in the patient's plasma is now provided by the normal plasma, and as a result, the APTT is getting corrected. So you know that you're dealing with a factor deficiency. On the other hand, what if there is no correction? What is the likely possibility? Why should there be no correction on mixing study?
Inhibitors.
Yes.
Hereditary fibrinogenemia.
Afibrinogenemia is again a deficiency. So that should get corrected on mixing studies. It's only inhibitors which will not get corrected because your normal plasma will have fibrinogen. So it will correct on mixing studies. But if there is no correction, it means that there is an inhibitor which is inhibiting the clotting factor in the patient's plasma. And that same inhibitor will also inhibit the clotting factors that you have provided in the normal control plasma. Yeah. So what are the possibilities if there is no correction? There could be inhibition either because of heparin. So either there is heparin contamination of the sample, or you are dealing with a lupus anticoagulant, which is another inhibitor, or there is an inhibitor specific to a particular clotting factor, or there is very high levels of FDPs or D-dimers, which is fibrin degradation products, which if present at very high levels can also inhibit. So the rationale of doing this is that if you're dealing with factor deficiency, such a patient will definitely benefit by receiving plasma or clotting factor concentrate. But on the other hand, if you know that you're dealing with inhibitors, in such a patient, plasma will not benefit and you have to use alternative bypassing agents. So what are the different reagents used for mixing studies? They are normal control plasma, which has more than or equal to 100% of all the levels, such that on mixing, at least 50% of all the all factors are present. H serum, adsorbed plasma, or specific factor deficient plasma. So now I'll just explain what is adsorbed plasma and what is H serum before we proceed further in this case. So adsorbed plasma is prepared by adding barium sulfate to 1 ml of control plasma, and it is kept at 37 degrees Celsius for 3 minutes. Now we know that 2, 7, 9 and 10 are vitamin K dependent factors. So because they are vitamin K dependent and vitamin K causes gamma carboxylation of these factors, they have a net negative charge because you know that carboxyl group has a net negative charge. So 2, 7, 9 and 10 have a negative charge. Now barium, if you all recall, barium sulfate is a insoluble compound. So these negatively charged 2, 7, 9 and 10 will get absorbed on the surface of barium. And finally, when you centrifuge it, the remaining supernatant plasma will have all the factors except for 2, 7, 9 and 10. Is this clear?
Yes, ma'am.
Yeah. So can one of you just repeat? Adsorbed plasma is deficient in which factors?
Vitamin K deficient dependent factors.
Very good. Vitamin K dependent factors 2, 7, 9 and 10. Because they are negatively charged, they get adsorbed on the surface of positively charged barium sulfate. And when you centrifuge and remove the supernatant plasma, it lacks in 2, 7, 9 and 10. Now coming to H serum. Can anyone tell me what is the difference between serum and plasma?
What we get by mild centrifugation is platelet-rich plasma.
Serum is devoid of clotting factors.
Yes, serum is devoid because you have allowed the blood to clot. So serum does not have one, which is fibrinogen, factor 2, all that is consumed in the process of clotting. And now if you allow this serum sample to stay for 2 days at room temperature, even 5 and 8 being labile are removed. So such a serum is called aged serum because you have allowed it to age for 2 days. So over the period of 2 days, the aged serum has all the clotting factors except for 1, 2, 5 and 8. Is this fine?
Yes.
Okay. So now let us look at our patients' mixing studies. So we saw that the patient's mixing study with pooled normal plasma gives an APTT of 35 seconds. What does that tell you? What are we dealing with?
Deficiency.
Factor
Factor
deficiency.
deficiency.
Very good. Factor deficiency. So the next step is we want to narrow down the diagnosis. We want to know what we are dealing with. So we do the mixing studies with 8 serum and adsorbed plasma. So now when you're doing mixing study with 8 serum, the APTT is 90 seconds. But with adsorbed plasma, it is 37 seconds. So what could be the possible diagnosis?
Hemophilia
That
A.
there is deficiency of either 1, 2, 5 or 8.
Yeah, but this patient has
X.
isolated APTT prolongation, right? So 1 or 2 will not cause isolated. So let us look at a diagram to understand this better. So now we know that already based on the history, based on the isolated APTT prolongation, we know that we are either dealing with 8 or we are dealing with 9, because that is the answer that all of you gave me. So now we know that there is isolated APTT prolongation of 92 seconds. Now adsorbed plasma does not have 9 out of 8 and 9. 8 serum does not have 8. Now when you're performing the mixing studies, you see that on mixing with adsorbed plasma, there is complete correction, but on mixing with 8 serum, there is no correction. Now, after seeing this diagram, can anyone answer this question? Any one of you?
Factor 8 deficiency.
Factor 8 deficiency.
Factor 8 deficiency.
Hemophilia A.
Very good. Why? Because you know that patient has isolated APTT prolongation, and possibly the patient does not have 8. 8 serum also does not have 8. So now mixing 8 serum with the patient's plasma is not going to help. And as a result, the APTT still remains prolonged. On the other hand, the adsorbed plasma has factor 8. It does not have factor 9. And as a result, the adsorbed plasma is able to give you complete correction. Is this fine? So correction with adsorbed plasma, but no correction with 8 serum in such a patient with isolated APTT prolongation is factor 8 deficiency. So what is the next test that you want to perform?
Replacement. Factor
Specific
8 assay.
Yes, very good. We would perform factor assay in order to classify the severity. So in this case, we perform the factor 8 assay and which showed less than 1%, which means it is severe hemophilia A. A factor level of less than 1 is severe, 1 to 5 is moderate, and 5 to 40 is mild. Okay. So now coming to the second case, 7-year-old Tsar. So Tsar is the name of the son of the emperor of Russia. He had hemophilia, and let us see what our Tsar has. So we'll go through the history and see what our 7-year-old Tsar has. So this is 7-year-old boy who presented with uncontrolled bleeding following fall 3 days back. He has been brought to the hospital where he was given factor concentrate, which stopped the bleeding. He has history of spontaneous large swelling at the back of the thigh with discoloration. He has been symptomatic since 1 year of age, presented with prolonged bleeding from wounds following falls, history of knee pain with knee joint swelling, now walks with a limp. Family history, his 25-year-old mother says she has easy bruisability and tooth socket bleeding, but nobody else in her family has a bleeding problem. She is the youngest of 9 siblings. Her father, who is 70 years old, had a hernia repair which was uneventful, and maternal uncles are asymptomatic too. So is this patient a bleeder or non-bleeder?
Bleeder.
Everyone is on the same page? Definitely. The patient is a bleeder. He has required multiple times factor concentrates, mild or severe.
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 Why severe?
Severe.
Bleeding from joint.
Spontaneous bleed, multiple histories.
Muscle bleeding.
Deep sea.
Muscle bleeding, joint bleeding is telling you the whether it's a primary or secondary
Spontaneous.
hemostatic defect. But it
Even
is
bleeding-
it is
Bleeding from
spontaneous.
minor
It has,
wounds.
Yes,
Spontaneous
it is-
bleed requiring therapy.
correct. Spontaneous bleeding requiring factor concentrates. So it's a severe bleeding. Primary hemostatic defect or secondary hemostatic defect?
Secondary
Secondary hemostatic.
Why? Why secondary?
deep since it's a deep sleep.
Yes, very good. Because he has
Muscle.
history of deep bleeds, bleeding into the muscles and joints. So it's a secondary hemostatic defect, inherited or acquired.
Ma'am, it
Ma'am,
seems as inherited because
Inherited, ma'am.
mother has symptoms. It might be autosomal recessive.
Okay, we'll see that.
possibly inherited. Possibly.
Yeah, look,
So,
see, if you look at the history, the child has been symptomatic since the age of 1 year.
One.
So, since a very young age, he's been symptomatic. So, inherited, right? So, what is your possible diagnosis based on the history?
Hemophilia A, B, von Willebrand disease,
Volvin
type 3.
right, Normandy is
Okay,
very.
fine. So, maybe hemophilia A or
Yeah.
B, as many of you told me. So, what is the mode of inheritance for hemophilia A or B?
X-linked.
X-linked recessive.
X-linked recessive. Very good. So now going back to our patient's family history. So as you rightly pointed out, the 25-year-old mother says she has easy bruisability and tooth socket bleeding. She's never required consultation, but this history is only on probing. And nobody else in her family has any bleeding problem. She is the youngest of 9 siblings born to parents who are farmers. The maternal grandfather, who is 70 years old, had a hernia repair which was uneventful, and all the maternal uncles are asymptomatic too. So, looking at this history, does it look like X-linked recessive? If you see
No.
the males on the maternal side, the maternal grandfather, maternal uncles, all of them are asymptomatic. Okay, so if I tell you this is still hemophilia, what is the possible explanation if your diagnosis is still hemophilia?
De novo.
Adopted.
Okay, so these are the options. So 7-year-old boy, diagnosis of hemophilia, but no family history. What could be the possible reasons? A, acquired hemophilia A, yes or no?
No, ma'am.
No.
No.
Everybody agrees?
Yes.
Okay, so acquired hemophilia A classically presents in elderly individuals, and the history is very classical where the person would have been asymptomatic previously, and suddenly there is a history of unusually large bruises, huge ecchymosis or bruises, which can be unexplained by the extent of trauma. Even trivial trauma will cause large subcutaneous hematomas. So that is a classical history that you get for acquired hemophilia A, which is an autoimmune condition where there are autoantibodies to factor VIII. So it usually presents in elderly individuals. But our patient is a child who has been symptomatic since 1 year of age. So as all of you rightly said, not acquired hemophilia A. Could it be de novo mutations?
Yes,
Yes,
ma'am.
Yes. Okay. Could it be disputed paternity?
No, ma'am.
Why no?
No.
Ma'am,
Ma'am, a boy inherits
Mother's X chromosome has.
mother's X.
Yes, very good. Because it is X-linked recessive. So X-linked recessive disorders, the mother is the carrier and she transmits it to the male child. A father is not going to transmit it to the male child. So you are right. It cannot be disputed paternity. Can it be adopted child?
Yes,
ma'am.
ma'am.
Yes,
Can be,
ma'am.
right?
Yes, ma'am.
Possible.
Possibility.
So the
Possible.
only two possible options, very good. So only two possible options here is either de novo mutations or adopted child. So on probing the history, we know that he was not the adopted child. So we are left with only one possibility, which is de novo mutations. So what is the reason behind these de novo mutations? If you go back and see the history, the 25-year-old mother is the youngest of the 9 siblings, and the maternal grandfather, that means mother's father, is now 70 years old. So now this means that if you look at this family tree, and the arrow here shows our patient, and the mother is possibly the carrier. This means that the mother was born to her father when her father was 45 years old, because currently the mother is 25 years old and the maternal grandfather is 70 years old. This means she was born when her father was 45 years old. And it is known that spermatogenesis at age more than 9 years can cause de novo mutations. So this clearly explains why there was possibly de novo mutation at the time of spermatogenesis. So the mother becomes an obligate carrier. Though all of her siblings are not affected, but she becomes an obligate carrier due to de novo mutation, and as a result, she transmits it to her male child. Is this clear?
Yes, ma'am.
So now going back to the mother's history. Now we all know that mother is an obligate carrier. But why is she symptomatic? She gives a history of easy bruisability and tooth socket bleeding. So why is the mother
Ionization.
Lionization.
Okay, yeah. So the possible options were, is she homozygous or if there is skewed lionization? As all of you correctly told me, it is because if had she been homozygous, she would have been much more symptomatic. She has never required a consultation. She just gives history of bleeding upon probing. So it shows that there is a skewed inactivation of X chromosome, but she is not severely symptomatic. So the learning from here is that you may be dealing with a case of hemophilia with a negative family history, but it does not rule out the possibility of it being hemophilia because it could be a de novo mutation. And even the carriers can be mildly symptomatic because of skewed lionization. So now, what tests are likely to be abnormal and which tests will you make to arrive at the specific diagnosis?
APTT is increased.
Yes, correct. So let us look at the lab results. The platelet count is normal, the PT is normal, and the APTT is again prolonged and 92 seconds. What is the next step that you do?
Mixing study.
Mixing studies.
Very good. You do mixing studies. So we did the mixing study with pooled normal plasma. It gives a value of 35 seconds. What does it tell you?
Factor deficiency. As corrected.
Yeah, so we are dealing with a factor deficiency. So we did the 8 serum and adsorbed plasma mixing studies, and the 8 serum is giving a value of 39 seconds and the adsorbed plasma is 37 seconds. So how do you interpret this?
With A serum, APTT has prolonged.
It is
And
still a correction. I mean, 0.6 seconds is not it is still correction. Both of them are correcting. So we know that if there is hemophilia A, there will be no correction with 8 serum. Because 8 serum lacks factor 8. And if it is hemophilia B, there is no correction with adsorbed plasma. Because adsorbed plasma lacks factor 9. But here, in this case, there is a good correction with everything, with normal plasma, 8 serum, and adsorbed plasma. So then what are we dealing with? You must understand that adsorbed plasma and 8 serum can have quality issues because they are prepared in-house. So suppose if you have under-adsorbed, you have not properly adsorbed it, it is possible that the factor 9 is still there. And as a result, it will correct for hemophilia B plasma. On the other hand, if you over-adsorb, which means that if you allow the adsorption to go beyond 3 minutes and if you allow it to remain for a longer time, it may get over-adsorbed. So this means that not only 9, but other factors will also get removed. Even the factor 8 may get removed. And as a result, it will not correct for hemophilia A plasma. So it is very important to ensure the quality assurance of adsorbed plasma. This can be done by performing a simple PT on the adsorbed plasma that you have prepared. If the prothrombin time on the freshly prepared adsorbed plasma is more than 60 seconds and less than 120 seconds, it tells you that you are dealing with a good quality adsorbed plasma. It is neither under-adsorbed nor over-adsorbed. Similarly, okay, so before I go to the 8 serum, I have a question. 8 serum contains which of these? Factor 9 and 10, 8 and 5, 9A and 10A, or 8A and 5A?
9A and
9
10.
and
9 and 10.
9 and 10.
9 and
I am
10.
getting two responses, 9 and 10 or 9A and 10.
9 and 10,
Give
ma'am.
it at 9 and
So how is the serum prepared? As we already discussed, you have allowed the blood to clot.
age.
Clot, it's called clot.
Clot.
Yeah, so you have allowed the blood to clot and then there is serum. So when the clotting process is already initiated, you have 9A and 10A. You have activated factors 9 and 10. Clear?
Yes,
Yeah.
ma'am.
So just like the adsorbed plasma, which can have quality control issues, similarly, even the 8 serum can have quality issues. So 8 serum contains 9A, 10A, but it does not contain 8. But we know that we cannot complete the coagulation without 8. So now what if, is it possible that your 8 serum is also falsely giving complete correction with hemophilia A plasma? Yes, it is possible if it is not a good quality 8 serum. Now, what do I mean by not a good quality 8 serum? It could be that you have aged it for less than 48 hours. You did not allow it to age for 48 hours, and as a result, all the factor 8 is not removed. It still has residual factor 8. In that case, if you use that 8 serum to perform a mixing study, it will give a correction even for hemophilia A plasma. Another possibility is that if the donor whose serum you had used had a very high levels of factor 8 of more than 200%, even after allowing it to age for 48 hours, all the factor 8 may not still be removed. So even the 8 serum has a quality issue. So how do you overcome this? You cannot, like you did a PT on adsorbed plasma to look at the quality. Can you do anything similar on 8 serum? Can you perform a PT or APTT on 8 serum?
PT.
8 serum does not have factors
2, 7.
1 and 2.
1 and 2, 7.
Does not 1, 2, 5 and 8, right? So does not have prothrombin, does not have fibrinogen. So it is not going to clot. So you cannot perform that test. So the quality assurance can be done by using 3 separate 8 sera. So you use 3 separate, you do not pool them, but you use 3 different 8 sera and you perform 3 different mixing studies and you ensure that results of at least 2 of them should be similar. So this is the how you take care of the quality assurance of 8 serum. Now going back to our patient 7-year-old Sar, the APTT is 92 seconds, giving complete correction with normal serum, normal plasma, 8 serum as well as adsorbed plasma. So we clearly know that we are making some mistake, either in the quality control. So an old man once said that erasers are made for those who make mistakes. So a wise youth replied that erasers are made for those who are willing to correct their mistake. So it is the attitude which matters. So it is okay to make mistake, but you should know how to rectify it. So how will you rectify the mistake here? So it is very simple. If you if you're a treatment center where you can easily get the factor concentrates, the vial which is remaining after the factor concentrate is given to the patient will have few drops of factor 8 remaining. So even if you can extract a few drops, it is sufficient. You can note down the dose. It is usually 100 units per ml. Now, suppose you're able to extract even 20 microliters of factor 8 concentrate, which is remaining in the vial. And if you dilute it 1 in 4 with saline or distilled water, take 6 microliters of this and add it to the patient's plasma and you repeat the APTT. So basically, you are adding diluted factor 8 concentrate and you're performing the APTT on the mixture. If the APTT gets corrected, it is factor 8 deficiency. But if it is not getting corrected, it could either be factor 9 deficiency or it could be high titers of inhibitors to factor 8. So then how do you differentiate this? You can use similarly factor 9 concentrate, few drops of the vial from factor 9, few drops from the factor 9 vial, and you can perform a similar mixing study. Now coming back to our case, we did the similar spiking thing with factor 8 concentrate, but it did not correct the APTT. So what is your most likely diagnosis? Is it an inhibitor? Is it a high titer inhibitor?
No, it
Or
is
it could
factor 9, more towards factor 9 because
9 deficiency.
there is correction that was happening. So
Correct. Yes, very good. So because it cannot be a high titer inhibitor because we were getting correction in the previous mixing studies. And even if you look at the history, the patient was responding to the factor concentrate recently and the bleeding was stopped. So we performed the APTT after spiking it with factor 9 concentrate and it showed complete correction. So what is the diagnosis?
hemophilia B.
Hemophilia B.
Excellent. So it's hemophilia B. Okay. So now going to the third case. This is a 45-year-old gentleman and he is presented from a village nearby to Vellore in Chittoor district of Andhra. And he presented with a large, painful bluish black discoloration in the left thigh. There is no past history of bleeding. So a USG was performed at the site of bleeding and it showed temporal evolution of large subcutaneous bleed. So there was definitely a large subcutaneous bleed, but there was no evidence of any intramuscular hematoma. So looking at the initial investigations, the hemoglobin was reduced 7.1 gram per deciliter. The platelet count was normal and the blood picture showed normochromic normocytic blood picture. So looking at the coagulation profile, PT is more than 2 minutes, APTT is more than 3 minutes. What next?
Thrombin time.
From
Common
before
pathway
that?
defect.
What do you do
Common
when
pathway.
what do you do when your PT or APTT is prolonged? Going
Mixing
back,
mixing
mixing
Mixing.
studies.
First we'll do
mixing.
TT, ma'am.
First we will do mixing studies,
Yeah.
right? That's what we discussed in the. So whenever you have a prolongation, how do you know that it is deficiency or inhibitor? So when you have prolonged PT and APTT, you do the mixing studies. Now mixing studies is giving complete correction of both PT and APTT. Now what next?
TT.
TT.
Thrombin
Very
time.
good. Yes, so next you do the thrombin time. So thrombin time is also prolonged, 31.9 seconds. What next?
Mixing studies with
Yes.
8 Sera and
Yes.
8.
So
Correct.
first step for anything is, so the basic rule is if you have prolonged PT, APTT, TT, anything, the first step is to do mixing study for the same test using pooled normal plasma.
Pool
To
normal.
know whether you are dealing with a deficiency or not, right? So here the thrombin time is prolonged. So what next you do? You do a mixing test for thrombin time. So now you do a mixing test for thrombin time, which is showing complete correction. So what is the next test that you want to do if thrombin time is prolonged and it is correcting?
With adsorption.
fibrinogen level.
Yes. Suppose, okay, let me ask another. If the thrombin time was prolonged and if it was not correcting on mixing study, what could have been your possible answer? What could have been the possibility?
DIC.
DIC.
DIC is factor consumption then, or it should correct on mixing studies. If there is no correction of a prolonged thrombin time on mixing study, you think about
Inhibit.
what
Inhibit.
inhibitor?
Inhibit.
What inhibitor
heparin.
will cause thrombin time? Heparin, yes.
Well,
So most common things first. So you think of heparin contamination. But here you see that the thrombin time is getting corrected. So what is the next test? I think as Kapil rightly replied, what is the next test that you would
Fibrinogen
perform?
level. Fibrinogen level.
Yes. So we did the fibrinogen assay and the fibrinogen assay showed undetectable levels of fibrinogen. So what are we dealing with?
Fibrinogen deficiency.
Yeah, looks like afibrinogenemia, right? Looks like afibrinogenemia. But if you look at the history, and if you dig more into the history is not like, because afibrinogenemia is congenital. Now this is a middle-aged man with no comorbidities. He has no past history of bleeding symptoms. He works in the farm and he has had multiple injuries and scratches from thorny bushes, which he collects for fencing. He has fallen multiple times from his motorcycle, but he has never bled extensively. So this rules out the diagnosis of congenital afibrinogenemia. So now what could have caused such a huge hematoma? So now we probe more into the history. So we asked him again and asked him to recall and recollect if he could really think of what could have possibly caused this hematoma. So then on further probing, he says that 1 week back, he had been carrying the thorny bushes, which was tied onto the motorcycle, and he did feel a sharp pain into the left thigh, which he attributed to possibly a large thorn, but he can't remember clearly. He vaguely remembers that some large thorn-like prick injury had happened to the thigh, and possibly that could have caused the hematoma. He's not diabetic, and there is no other risk factor to develop cellulitis. Okay, so now how will you manage this patient? A, wait and get more clarity because you think you don't still have a possible diagnosis. B, Paxil, C, FFP, or D, cryoprecipitate.
More
We'll give
clarity.
cryoprecipitate, ma'am.
So I think these answers are coming from the slides which I had already sent out because the next slide is on cryoprecipitate. But do you think you have enough clarity on this?
No, ma'am.
No, right? You don't have, because it is not congenital afibrinogenemia. That is what we feel from the history. So the most logical thing is to get more clarity on this case. So, but the physician still demanded for products. He said he still wants the products because there is a large hematoma which can possibly explain the drop in hemoglobin. His hemoglobin was 7.1. So he asked for Paxils and cryoprecipitate in view of undetectable levels of fibrinogen. So now cryoprecipitate was transfused. 6 units of cryoprecipitate were transfused, and these are the parameters which are seen after transfusing cryoprecipitate. After giving cryoprecipitate, the PT is still more than 2 minutes, and the APTT is still more than 3 minutes, and the fibrinogen is undetectable. So there is no change in the parameter even after the cryoprecipitate transfusion. So what is the likely diagnosis? Is it DIC, hyperfibrinolysis, congenital afibrinogenemia, or defibrination?
Defibrination.
Type
Ma'am, hyperfibrinolysis.
DIC.
Defibrination.
Okay, so I'm getting all the possible options. So let us go back and look at the case. So now, if you recollect the history, this man only has a large subcutaneous hematoma. He's happily wandering about the ward. No other things. The platelet count is completely normal. So DIC is unlikely. Now, as far as hyperfibrinolysis is concerned, he has not received any fibrinolytic agent. There's no history of why should it be suddenly hyperfibrinolysis. So there is no history. Now, if we know that based on the history, it doesn't look like congenital afibrinogenemia. Further, to support that, we did a D-dimer, which is 6,000, more than 6,000, and we know that the source of D-dimer is fibrinogen. So a patient cannot have such a high level of D-dimer if he did not have fibrinogen in the first place. So what is the only option we are left with?
Defibrination.
Defibrination. Yes, very good. So it's not afibrinogenemia. So only option that we are left with is defibrination. So now when we Google this word defibrination, if you Google it and you see in the Google, these are the possible explanations that come up, which is DIC, streptokinase, which is a fibrinolytic agent, and these are various snakes and Angistrodon rhodostoma, botrops, which produces the reptilis venom, and rattlesnake. So what is the possible answer here?
Snake bite.
Snake.
Which of these?
Rattlesnake. Viper, ma'am.
Viper.
Okay.
It's hemotoxic.
So amongst
Andhra,
these three
rattlesnake.
snakes which I showed you, out of these three snakes that I showed you, none of these snakes exist in Andhra, not even in India. But you are all right. It is still a snake and it is a viper. So this is the
Sauce.
sauce-tailed viper,
Sauce-tailed
which
viper.
is Achis carinatus. So now Achis carinatus produces the snake venom, which is icarin. So now what is the action of icarin? Icarin acts as a prothrombinase complex. So now if you recall this prothrombinase complex, icarin has factor 10A, 5A, phospholipids and calcium. It only lacks in factor 2. So it does not require phospholipid, it only requires prothrombin. So what it does is, anywhere in the circulation, it converts all the prothrombin to thrombin. And all this thrombin finally will convert fibrinogen to fibrin. And as a result, it results in defibrillation. So is the mechanism of action of icarin clear? It's a prothrombinase complex and it has all the components of a prothrombinase complex. It only requires thrombin in circulation. The moment it gets the thrombin, it converts it into, the moment it gets prothrombin, it converts it into thrombin, and which converts fibrinogen to fibrin. So now we inform the physician that this looks like a snake bite and you should perhaps give anti-snake venom and not cryoprecipitate. But the physician says they were not interested. There is no alleged bite marks. There is no alleged bite, there is no bite marks. Now the skin there had become so edematous that it is even difficult to appreciate any bite marks. So the physician said they still wanted blood products. So our advice was that blood product will not be given, and it will be given only if there is either a drop in hemoglobin or an extension of the hematoma. If the hematoma extends in its size, we will give cryoprecipitate. But if there is a drop in hemoglobin, we will also give Paxil. Yeah, but to the misfortune of the physician, neither the hematoma extended nor was there any drop in hemoglobin. The patient kept happily wandering about the ward with the huge hematoma which was already there. There was no change in the size of hematoma. So finally, after 2 days, the physician had no choice but to listen to us. And finally, they decided to give anti-snake venom. So after 2 days of waiting, anti-snake venom was given. And these are the parameters which were seen after giving ASV. So after ASV is given on 14th, because for 2 days they didn't respond. And on 15th, if you look at the parameters, the PT, which was more than 2 minutes, has become 28.6. The APTT, which was more than 3 minutes, has become 35.5 seconds. And the fibrinogen, which was undetectable, has started becoming detectable. So the physicians got the bite of their life. Now, a frantic search for the fang marks began in an edematous discolored area. Now, some potential skin pores started appearing as potential fang marks. So now they started believing that, yeah, possibly this is a snake bite. And these are the repeat parameters that you can see over the period of this patient's hospital admission as the anti-snake venom was given. The APT started becoming normalized. The APTT, on the contrary, even shortened. The D dimer reduced, and the fibrinogen, which was previously undetectable, had reached a value of 93. So now, if you look at this, the thrombin time is 31.9 seconds, even when the PT and APTT are significantly prolonged. So why is it that the thrombin time is not so prolonged, even when the fibrinogen is undetectable? Is it a false result, poor lower limit of detection of von Closs fibrinogen, soluble fibrin monomers, or FTPs?
Fibrin degradation products.
Peace.
Okay, so I'll explain this in the subsequent slide. It is soluble fibrin monomers. So if you look at this diagram here, So I showed you the picture of the icarin, which is a prothrombinase complex. So that will convert prothrombin to thrombin. Now this thrombin will convert fibrinogen to soluble fibrin monomers. But so it is at this stage. Now at this stage, the moment you add the thrombin reagent, it immediately polymerizes and it gives you a clot. So as a result, the thrombin time is prolonged, but it is not significantly prolonged because there is increase in soluble fibrin monomers. So to revise again, the venom of Achis carinatus, which is icarin, is a prothrombinase complex, as against textarin, which is produced by another snake, which is Pseudonaja textalis, is also a prothrombinase complex, but it does not have phospholipids, whereas this icarin also has phospholipids. So icarin will convert prothrombin to thrombin anywhere in the circulation. This thrombin will convert fibrinogen to soluble fibrin monomers. So this is the process of defibrillation. Is this clear?
Yes, ma'am. Yes, ma'am.
So now we go to the next case, which is a boy from Kerala. This is a 6-year-old boy who presented with history of easy bruisability and spontaneous epistaxis from both the nostrils, requiring consultation for last 6 months. He's 6-year-old. He's symptomatic for last 6 months. All the episodes were treated with pressure and ice application. No past history of bleeding. The child has also undergone a surgery. He's undergone a circumcision at the age of 3 years, but there was no excessive bleeding during that surgery. Family history: he's born of non-consanguineous marriage, and there is no significant family history of bleeding. So, looking at the BAT score, there is epistaxis, which required consultation. So that gives us a score of 2, and there's cutaneous bleeds, which is present. So it gives an additional score of 1. So the total score is 3. So is this patient a bleeder or non-bleeder?
Bleeder.
Bleeder, because the cutoff for a child is 3 or more
Three or
than
more than 3.
Yes, so it's a bleeder. Mild or severe?
Severe.
Mild.
Mild, ma'am.
Severe.
Severe, ma'am. 3 or more than 3 is severe.
So again, to clarify this, a score of 3 or more than 3, 4 or more than 4, or 6 or more than 6 will only tell whether the patient is a bleeder or non-bleeder. It will not tell you the severity, because the bleeding history can be very subjective. What I can feel as excessive bleeding may not be excessive bleeding. So in order to make it more objective and to identify actual bleeders, we have this scoring system. So a score of 3 or more than 3 is only telling you that this patient is bleeder. But how do you assess the severity of bleeding?
Ma'am, any hospital admission will score.
Requiring cryoprecipitate or
So yeah,
Replacement
requiring
therapy or-
bleeding. Yes, so bleeding requiring transfusions, replacement therapies, uncontrolled, prolonged bleeding, even with my trivial, minor, without significant provocation. So these are severe bleedings. So a score is only used to identify a bleeder from a non-bleeder. It is not to grade the severity. Severity is based on the history. So again, now is this clear? Now is based on the history, is this patient mild or severe?
Mild.
Mild.
Everyone agrees?
Yes,
ma'am.
Yeah. So the only history that we have is epistaxis and cutaneous bleeds. And if you could recall, it was all controlled by pressure and ice application. He never had to be taken to the hospital. Yeah. So it's mild. Inherited or acquired?
Acquired.
Ma'am,
Yes.
I'll go sporadic.
possibly inherited.
Inherited.
Okay. Why inherited and why acquired? If somebody told me acquired, why do you think it is acquired?
Ma'am, because at the age of 3, the patient had a circumcision and did not have any complaints of bleeding. The symptoms started only in the last 6 months, and also there's no family history or any significant past history.
Excellent, excellent. Very correct. As rightly mentioned by Purvi, So because the patient has had a past surgery which was uneventful, he's 6 years old, though he's a child, but the symptoms have started only for last 6 months. And he's had no past bleeding even during surgery and no family history. So looks like acquired. Primary hemostatic defect or secondary hemostatic?
Primary.
hemostatic.
Why primary?
Only mucocutaneous.
Mucocutaneous bleeding is there.
Very good. Yes. So looks like a primary hemostatic defect. What is your possible diagnosis? If it is a primary
Platelet
hemostatic
defect. Platelet defect or a one.
Platelet
Yes.
function defect.
Or a,
Von
as Sherry
Von
said,
Willebrand.
or yes, correct. So it could either be platelets related or it could be a von Willebrand factor related. So what tests would you like to perform in this child?
First of all,
Platelet count,
platelet count.
PS examination.
Platelet count, PT, APTT.
FA, agree.
Okay. So what tests do you perform for primary? What are the screening tests for primary hemostasis?
Platelet count, bleeding time.
Bleeding time, APTT, PT.
Yes. APTT PT is for
Secondary hemostatic defect.
Yes. So just considering the history and considering that you are thinking of primary, the screening tests which will perhaps help are
Platelet
bleeding
count,
time.
Platelet count and
Yes,
bleeding time.
platelet count, morphology, and bleeding time. So we'll see. So looking at the child's investigations, the hemoglobin is 11.9 gram per deciliter. The total count is 18,000. And if you look at the differential count, there are 37% neutrophils, 44% lymphocytes, 11% eosinophils, and 7% monocytes. And peripheral smear shows mild red cell anisocytosis, hypochromic microcytic red cells. There's platelet anisocytosis and isogranularity, and eosinophilia on the smear. The bleeding time is 7 minutes. And PFA, I'll come to what is PFA, which is another screening test for primary hemostasis, shows prolonged closure time with both collagen ADP and epinephrine. So I'll just explain you what is PFA. Before that, a brief word on how do you perform a bleeding time and what is a bleeding time. Bleeding time is the time taken by a standard skin wound to stop bleeding. Now, what do you mean by a standard skin wound? A standard skin wound is not a prick wound. It is a stab wound. So it is a wound which is 2.5 to 3 millimeters deep and 1 to 1.5 millimeters wide. So a lancet can be used to perform the bleeding time because the tip of the lancet is 3 millimeters long and 1.5 millimeters wide at the base. So the procedure to perform modified IV's method bleeding time is you tie the blood pressure cuff and you elevate the pressure to 40 millimeters of mercury. You select an area on the volar aspect of the forearm which is devoid of superficial veins, scars or angiomas. You clean that area and you make 3 confident stab wounds. Now the reason why you have to make three wounds is that considering that at least one of those wounds would be a standard skin wound, which means that a wound which is at least 3 millimeters deep and 1.5 millimeters wide. So because you are not sure whether it can be a standard wound or not, you're performing at least 3 wounds, considering that at least one of them would be a standard wound. And you start the stopwatch. Now you see that if it is a properly performed bleeding time, at the end of 30 seconds, you see blood welling up the wounds like this. And at an interval of every 30 seconds, you gently blot these wounds with the help of filter paper and make sure you do not dislodge the primary hemostatic blood. You gently blot from the sides. So you do this at every 30 seconds and you stop the stopwatch when all the 3 wounds stop bleeding. Normal bleeding time is 2 to 6 minutes, but it is ideal to establish your own range. And it will be prolonged in conditions with either von Willebrand disease, platelet function defect, or severe thrombocytopenia. The disadvantages of bleeding time are that it is time consuming, operator dependent, invasive because you're making 3 wounds, difficult to standardize, difficult to establish the range, but In a study done in our center, wherein bleeding time was done in 852 patients who presented with history of bleeding and were being evaluated for primary hemostatic defect, the sensitivity of bleeding time was 100% to identify severe bleeding disorders like Glanzmann's thrombocythemia as well as type 3 von Willebrand disease, and more than 85% even for Bernard-Solier syndrome. So, in a developing country like ours, where majority of the patients who are presenting to the hospital are severe bleeders, bleeding time done by the modified IVs method, which I showed you, is definitely a very good screening test for primary hemostasis, provided it is done as per the reference specifications. Now coming to understanding of what is PFA 200. PFA 200 is a test device, it requires a proprietary instrument. So you create a pseudo-physiological system. So this is the machine of PFA. It has a cartridge like this. You add 800 microliters of citrated blood to this, and the blood is aspirated through a capillary under high shear. Now, at the end of the capillary, there is a membrane which is coated with collagen and an agonist like ADP or epinephrine. Now, you know that when the von Willebrand factor is under high shear and it gets exposed to collagen, it unfolds like a carpet, which binds to the collagen, and there is formation of platelet von Willebrand factor primary hemostatic plug. Now, this primary hemostatic plug will close this aperture, and the time taken by the aperture to close is recorded. The closure time will be prolonged in patients with primary hemostatic defect. Is this clear?
Yes.
So basically, PFA 200 is also a screening test for primary hemostasis, but the major disadvantage of PFA is that it needs a proprietary instrument and it is extremely costly. So in a developing country like ours, it may not be a feasible screening test for primary hemostasis. So coming back to our patients, just showing you the screening tests for primary hemostasis, which is bleeding time is 7 minutes prolonged. PFA 200 is also showing a prolonged closure time. PT, APTT, and thrombin time are normal. You all mentioned that von Willebrand disease could be a possibility. So we performed von Willebrand factor ristocetin cofactor assay, which is the functional test for von Willebrand disease, which is also normal. So what is your possible diagnosis based on this?
Platelet function.
Defect.
Yes, very good. So what is the next test that you want to perform?
Aggregation test.
Yes, so you would, because both the screening tests are abnormal and the von Willebrand factor function is normal, you would want to perform the gold standard test for platelet function, which is light transmittance aggregometry. So looking at the aggregometry plots, we saw that there was normal response to ristocetin, a primary wave in response to ADP, and absent response to collagen, arachidonic acid, and epinephrine. So what is your possible diagnosis? A, Glanzmann's thrombocythemia, B, Bernard-Solier, C, von Willebrand disease, or D, none of the above?
Glanzmann thrombocythemia.
None of the above.
None of the above.
Okay, I can hear two answers. I can hear some people saying none of the above. So who says none of the above? One of you?
Yes, ma'am.
Yeah. So yeah, Kapil. So can you explain why do you think it is none of the above?
Ma'am, the platelet size that was given in the slide was 9.
I'm sorry, your voice is breaking. Can anyone else who is saying none of
9
the
ma'am,
above?
giant platelets in disease.
Okay,
Ma'am,
so I'll give
Ma'am,
you.
primary wave is deficient in Glanzmann.
Sorry.
Primary wave is deficient in Glanzmann thrombocythemia.
Correct. So if you see what is Glanzmann's thrombocythemia, I will come to a proper explanation, but just briefly, Glanzmann's thrombocythemia is absence of glycoprotein 2B3A receptor. Now, glycoprotein 2B3A receptor is required for platelet to platelet aggregation in response to all the agonists like epinephrine, collagen, ADP, and arachidonic acid. You cannot have a primary wave response, even this much response to ADP will not be there in a patient with Glanzmann, because the patient with Glanzmann does not have glycoprotein 2B3A receptor. Is this clear?
Yes.
Yes, ma'am.
Okay. So now to explain this better, so in a normal individual, you will see adequate response or normal aggregation in response to ADP, collagen, epinephrine, arachidonic acid, and high dose ristocetin. When I say high dose ristocetin, it is 1.5 milligram per deciliter, and there will be no response to low dose ristocetin, which is 0.5 milligram per deciliter. So this is a normal pattern which all of you should remember. Normal response to all the agonists is a normal pattern. In a patient with Bernard-Sollier syndrome or von Willebrand disease, what will happen is there will be no response to ristocetin, but a normal response to all the other agonists. Why is it so? Because what is the mechanism of ristocetin? Ristocetin will cause unfolding of the von Willebrand factor. So it will open up the von Willebrand factor, and it will enable binding of glycoprotein 1B receptor of platelets to the von Willebrand factor. So this is the mechanism of ristocetin. Now, what is the defect in Bernard-Sollier syndrome?
1B.
Yes, very good. So in
Mutation
Bernard-Sollier
1B.
syndrome, there is absence of glycoprotein 1B9. And in a patient with von Willebrand disease, there is either abnormal or absence of von Willebrand factors. So this explains why either Bernard-Sollier or von Willebrand disease patient will have no response to ristocetin, but a normal response to other agonists. Is this clear?
Yes.
Because response to other agonists requires the receptor glycoprotein 2B3A. Now, on the other hand, in a patient with Glanzmann's thrombocythemia, because the glycoprotein 2B3A receptor is absent, there will be no response to ADP, collagen, epinephrine, arachidonic acid, but just a cyclical response to ristocetin. Is this completely clear to everybody?
Yes.
Okay, fine. So now going back to our patient. So the patient has response to ristocetin, has a primary wave response to ADP, and no response to collagen, arachidonic acid, epinephrine. So what is the possibility out of the 4 options? None of the above.
None of the.
Right? So we are in trouble. We don't have the answer, right? So what does a pathologist do when he gets in trouble? What is the pathologist's favorite tool?
Microscope.
Yes, he looks under the microscope. So that's what the pathologist does when he gets into trouble. The last resort is look under the microscope. So this is exactly what we did. We saw the peripheral film under the microscope. And if you see that, even if you look at the counts, there is eosinophilia. So you were getting eosinophil almost in every field. And interestingly, if you look at the platelet morphology here, you will see that all these black arrows are showing platelets which are almost empty looking, degranulated, almost lacking the granules. On the other hand, these red arrows show platelets which do have some granules. So this means that there is platelet anisogranularity. Aniso means there is variation, and granularity is variation in the extent of granules present in different platelets. Again, seeing another field, again there is eosinophilia, and if you look at this black arrows, these are almost empty looking pale stained platelets, almost devoid of granules. And the red arrow shows that there are certain platelets which do have some granules. Okay, so now based on all this, what is your diagnosis?
Dense granules.
Granule.
Okay, so I
Positive.
know that all of you know the diagnosis, and I will extract the diagnosis out of you. So, okay, so is it inherited or acquired? Going back to
Acquired.
the same. Fine, it is acquired, right? Because it's a 6-year-old child, has had a surgery in the past, which was uneventful and symptomatic only for last 6 months. So everybody agrees with Purvi, it is acquired. Okay,
Understood.
it's a dysfunction of
Glycoprotein 2B3A.
Granules.
So
Granules,
basically,
lack of
so
granules.
broadly, it's a dysfunction of platelet, von Willebrand factor, or coagulation factors.
Platelets.
Platelet.
Platelets. Good.
Platelets.
So it's a platelet dysfunction. And what else you are seeing in the morphology, in addition to the platelet abnormality, what else is striking on the morphology?
Eosinophilia.
Eosinophils.
Exactly, eosinophilia. So here is your diagnosis. Just put all this together. The diagnosis is acquired platelet
Acquired platelet
dysfunction
dysfunction
with
eosinophilia.
eosinophilia, which is called APDE. So now what is APDE? Acquired platelet dysfunction with eosinophilia is a syndrome characterized by reversible spontaneous hemorrhagic diathesis. The platelets have classically bizarre shape and pale staining poor granules, and there is eosinophilia. This was first described in 1975, and this was initially called non-thrombocytopenic purpura with eosinophilia. This is most common bleeding diathesis in children in Thailand. So clinical manifestations, most commonly, most of the patients are children residing many times in coastal areas, and there is history of mild symptoms like ecchymosis present in almost 100% of those patients, and severe bleeding like intracranial hemorrhage is almost non-existent. So most of these patients will have very mild mucocutaneous bleeds, most often ecchymosis. So the postulated pathophysiology of APDE is that because of parasitic infestation, there is eosinophilia and elevated levels of IgE. This in turn will activate the mast cells and cause release of platelet activating factor from the mast cells. And the immune complexes of IgE will get bound to the surface of the platelets. So both platelet activating factor and the immune complexes will activate the platelets and will cause degranulation. And as some of you rightly suggested, it is a storage pool, but it's an acquired storage pool condition, which is because of APDE. So because the platelet granules are degranulated, they are no longer functionally effective. So it creates an acquired storage pool defect. So as far as lab findings are concerned, there will be eosinophilia, there may be mild leukocytosis, the platelet count is normal, few of the patients may have mild thrombocytopenia, but the most pathognomic finding is platelet morphology. Platelet morphology shows pathognomic pale stained platelets with very few granules and platelet anisogranularity. Now, bleeding time may be prolonged in around 60% of the patients. PFA may be abnormal in 90%, but the abnormal platelet morphology correlates with the severity of clinical bleeding, and the abnormal platelet morphology is present in 100% of the patients. These are the various light transmittance aggregometry patterns that you can get in APDE. So what I want to teach you from this slide is that the pattern which I showed you was not specific for APDE. APDE does not have any specific aggregometry pattern. Basically, the response to ristocetin will always be normal, and there may be a decreased response to one or more agonists, but it will not fit into your classical pattern for Glanzmann or Bernard-Soulier or von Willebrand disease. Is this clear? So it can have any of the patterns. So how will you manage this patient?
Antihelminthic.
Treat the parasitic.
Excellent. Yeah. So simple. Give antihelminthics, treat the cause, treat the eosinophilia, and the platelet dysfunction also disappears, and the patient becomes asymptomatic. Very good. And finally, going to the last case for the day, which is Mrs. S. She is a 28-year-old full-term who presented to the labor room. She's bleeding with severe coagulopathy after delivery. She's transfused with 8 red cells, 8 units of FFP, and 16 units of platelets. After all this transfusion, the parameters were repeated. Platelet count is 12.1 seconds, which is within the reference range, with an INR of 1.03. The APTT is normal. Fibrinogen is 155 milligram per deciliter, and the platelet count is 1,50,000. So all the parameters look within the reference range, but she continues to ooze despite these test results. Okay, so why do you think are the test results not reflecting clinical bleeding? Which test will help reflect clinical bleeding in a case of PPH, and how will you manage the patient to stop bleeding? Any clues?
Ma'am, because after transfusion, since the transfusion was done, that is why there's a replacement of the factors, and that is why it's not reflecting the clinical bleed. Ma'am, FDP or D-dimer might help us in understanding why there's a clinical bleed possible, and we need to treat the PPH to actually manage the patient.
Okay, so we'll see. So you mentioned that possibly because we have transfused, the parameters became normal. But
Yes.
I would, if the parameters have become normal, she should not continue to bleed, right? So here the problem is, even after transfusion, when the parameters seem to be within the reference range, the bleeding still continues. If the parameters become normal, she should not continue to ooze. So now this is a difficult case, so I'll not trouble you more.
Maybe there is a hypocoagulable state.
Yeah, so I'll just take you through this case. Maybe this is more for a teaching exercise. So management of obstetric bleeding is many a times based on the data derived from massive trauma. So if you could recall, this patient had received red cells, FFP, and platelets in a ratio of 1:1:1 or 2:1:1. Now, monitoring of obstetric bleeding based on the data derived from massive trauma, and as far as massive trauma is concerned, the critical level of fibrinogen which is considered is 100 milligrams per deciliter. So when you're treating a patient with massive trauma, you target to maintain a fibrinogen level of more than 100 milligrams per deciliter. Now at that level of fibrinogen, PT and APDT will become normal when the fibrinogen is more than 100 milligrams per deciliter. But you must understand that pregnancy is a different physiology. Pregnancy is a completely altered physiology, particularly as far as coagulation is concerned, and cannot be seen likewise as a massive trauma, because during the pregnancy there is increase in various procoagulant factors like von Willebrand factor, fibrinogen, factor 8, reduced anticoagulant factors like protein S, and there is resistance to activated protein C. So it's an altered physiology. So one size does not fit all. You cannot straight away use the irrational ratios which you could perhaps use for massive trauma to deal with a postpartum hemorrhage, because pregnancy is a different physiology. So the significance is that when you're managing a case of postpartum hemorrhage, the critical level of fibrinogen is not 100, but it's 200 milligrams per deciliter. So what is the significance of this 200? Severe postpartum hemorrhage is associated with reduction in the levels of fibrinogen. This is because as soon as the placenta is delivered, the fibrinogen level immediately drops from the below the normal pregnancy level sooner than any other coagulation factor. Many a times it goes even less than 200. And there is a strong evidence which is published in the literature that a low von Closs fibrinogen is an accurate biomarker for progression from moderate to severe PPH. So a fibrinogen level of less than 200 milligram per deciliter has a positive predictive value of 100% to predict progression to severe PPH. And a similar result is reported by another study which shows that a fibrinogen of less than 200 taken on an average 4 hours after the start of PPH was an independent predictor of need of an invasive procedure, including an obstetric hysterectomy. So the critical parameter to consider is to maintain a fibrinogen of more than 200 milligrams per deciliter. And when you have a fibrinogen of at this level, naturally all your coagulation tests, PT, APDT, TGT, ROTAM, everything, all these tests will be normal. So if you want to monitor a patient who is on PPH, the most important test is a want loss fibrinogen. So monitoring of obstetric bleeding cannot be based on data derived from massive trauma, where the cutoff is 100 milligram per deciliter, because 100 milligram per deciliter is too low to maintain adequate hemostasis. If it was 100 and if the placenta is delivered after that, it will go significantly lower. So the minimum level that you should aim at is 200 milligrams per deciliter. So the mandatory test which should be there in places where labor room exists is want loss fibrinogen. This test is also useful in trauma and DIC, and utilization of this test will help in minimizing the blood loss and control of bleeding. So the shock packs are the empirical 1:1:1 products based on the data derived from trauma which are given. So these unmonitored shock packs can actually be a killer in pregnancy. Why? Because most common cause of PPH is uterine atony or surgical or genital tract trauma. In these cases, it is unlikely to have early hemostatic impairment. Moreover, the patient will have 2 times higher coagulation factors than in the FFP. So, if you're giving FFP to such a patient, you are diluting her fibrinogen because the FFP has lower levels of fibrinogen than what the patient already has. So, by providing such large volume transfusion of FFP, you will dilute out the patient's fibrinogen, and because of the transfusion of FFP, the fibrinogen will drop below 200. So early unmonitored FFP can be dangerous. So what product would you like to transfuse for PPH in that case?
Cryopress.
Excellent. Yes. So the goal is to go, instead of massive transfusion, the goal is to go avoid massive transfusion and to make the patient stable. So as you rightly said, we will give cryoprecipitate. Even this patient received a full dose of cryoprecipitate so as to get the fibrinogen of more than 200 and the bleeding stopped. Okay, I'll thank you all, and I'm happy to take any questions.
Thank you, ma'am, for this for these such lovely and interesting cases and the lively discussion. And thank you, students, for your enthusiastic participation. It was really commendable on part of you all students. Now, I invite Dr. Sukesh Nair sir and Dr. Pankaj Malhotra sir for their comments.
Dr. Sukesh, are you going to make some comments?
No, I'm not. I'm waiting for your comments.
Okay. So, okay, I think Dr. Rutvi has presented in a very elegant manner, how to go about finding out a disorder. So it is, kind of a total mathematical approach. If you remember all the baseline, questions, how to go about this, and I would re-emphasize the history part of it. In all bleeding disorders, history is the most important thing to diagnose your bleeding disorders. For example, the farmer who had kind of a who was going around and till 45 years of age, he never had any problems, and then he suddenly came with the hematoma. So two things, which from the clinical point of view, when we are in the emergency, are first, any patient in even there is no history and who has come with just paraplegia or unconsciousness. It is a snake bite, especially post monsoon season. And the second, patient who has come with an unexplained bleeding disorder, again after the monsoon season. So post-monsoon season, the snake bites are very common, and you have to have a high index of suspicion to start the anti-snake venom, because many of these snake bites, especially which are which have coagulopathy as one of their side effects, can also cause renal dysfunction. So, and if you delay the administration of anti-snake venom, they can go into an irreversible kind of a, situation. So, the history again is very, very important. And uh, the other thing is, I would say, is that some of these patients, the first case was obviously hemophilia A and B, which you would see very commonly. But there are uncommon situations like eosinophilia with a platelet dysfunction, uh, which have to have a very high index of suspicion. And as Dr. Rutvi mentioned, that sometimes you have to look at the microscope, look at the morphology, and then you can make the diagnosis. So again, very, very interesting, and I hope the recording is there, and you should go through the recording, read the coagulation things again, and you will remember all these things in your whole of PG and even after that. Thank you.
I would like to add a comment. Dr. Lutfi was talking about SAR. Why is she talking SAR and hemophilia? Can anybody answer that?
Actually, sir, I
SAR is.
already had told them in the beginning. I don't know if they remember
Oh, is it?
I
Okay.
had given the answer to that.
But can anybody tell that SAR is related to somebody?
Russian
Royal
royal
Yeah,
family.
but the Russian king was married to Princess Alessandra, who was the most beautiful lady in Europe in those days. And Princess Alexandra is related to somebody whose funeral we saw recently.
Elizabeth.
Yeah, Princess Alexandra is the great aunt of Queen Elizabeth, and she's the granddaughter of Queen Victoria. So Queen Victoria is a person who was a carrier of hemophilia, though she didn't have any family history. She was born to her father when father was 52 years old, and that's how she got a de novo mutation of hemophilia. And also remember that if the trivia is asked, the hemophilia that the royal family had was hemophilia B and not A. So just a trivia for you.
Thank you, sir.
Okay. So with Dr. Pankaj's permission, I think we should.
So there are some questions which the
Okay.
attendees have posted in the chat box. So coming to the first question, Dr. Ifat has asked why the modified IV method for bleeding time is called modified IV. And she also asked why the BP cuff is used at 40 mm of mercury. And another question she has put up related to this method is that should we start wiping with filter paper immediately after pricking or after few seconds?
Okay.
That is.
So, to answer that question, first of all, why the blood pressure cuff is tied to 40 millimeters? So as to equalize the venous return. You want to make it standard, you want to equalize the venous return and maintain a constant pressure. So in order to equalize the venous return and standardize the procedure, you tie the blood pressure. There are many modifications that have come for the bleeding time test over the period of time. You would have read it in your books, like Duke's method, Ivy's method, modified Ivy's method. So there were some tests which were done on the earlobe, some tests. So this modified Ivy's method is that method where you are making 3 wounds, considering that at least one of the wounds is a standard skin wound. And yeah, as far as blotting is concerned, I would again like to revise that you should start blotting only after 30 seconds, not immediately, because you should allow the primary hemostatic plug to form. And the bleeding time, I must emphasize on this, is not a prick wound, it's a stab wound. So you should not use a needle to produce a bleeding time. The site is forearm where you put, and the reason why you make 3 wounds is considering that at least one of them was a standard skin wound, which is 2.5 to 3 millimeters deep and 1 to 1.5 millimeters wide. And every interval of 30 seconds, gently blot from the sides. Don't put it on the top of the wound so as not to dislodge the primary hemostatic plug, because you should even allow the primary hemostatic plug to form for the bleeding to stop. That's why don't start blotting immediately. Give it a time of 30 seconds and then do it at interval of every 30 seconds.
Okay. Dr. Ifat has asked another question, which is related to case 2. So she has stated in case 2, we can measure factor 9 to assess the deficiency of factor 9. Isn't it more easy than to add factor 9 after diluting? So
yeah, so so factor 9 assay is not readily available. Definitely the final thing is you have to perform a factor assay, but factor 9, even in if I tell you about our lab, we would have done mixing studies on commercial 8 deficient plasma and 9 deficient plasma in that case to know whether it is hemophilia A or hemophilia B. But commercial factor deficient plasmas are expensive, may not be available. So the solution which I showed in the case 2 was how to arrive at a diagnosis even if you are a resource poor setting. Doing a factor assay is definitely the solution. I am not trying to say that you can bypass that thing, but if you do not have resources, even in spite of that, you can still get a solution by using such simple measures where you can use the residual few drops of the remaining factor concentrate in the vial to perform the mixing studies and get a possible answer.
thank you, ma'am. There is another question. How to differentiate APDE from gray platelet syndrome inherited apart from eosinophilia?
So the history, as Sir Pankaj sir rightly mentioned, the most important thing is history. And all of you know that gray platelet syndrome is an inherited condition. And APD is an acquired condition. The history will be very classical. You will have a patient who has been previously asymptomatic, more commonly a child because of parasitic infestations, residing in an area, more often coastal areas, because you know that certain parasitic infestations will be more common there. And in addition to that, there will be anisogranularity in APD, where certain platelets have granules, certain platelets are completely empty looking. Most important, history will definitely tell you whether it's inherited or acquired.
Okay. Thank you, ma'am. Dr. Kavya has asked, can we have a decreased PT and APTT values in any situation?
Yeah, you can have shortened PT and APTT. So shortened APTT, if the factor 8 levels, factor 8 of more than 220 is a prothrombotic risk factor. So certain conditions where there is a prothrombotic, you can have shortened PT and APTT. It is possible.
Thank you, ma'am. So I don't see any more questions in the chat box. So I think so we can end our presentation for today. So, okay, so thank you, ma'am, and thank you, sir, for being with us. So before we end, uh, so a reminder to all our viewers. So regarding the upcoming talk on next Tuesday, that is on 27th of September, there will be a talk on issues in coagulation lab pre-analytical variables by Dr. Dinesh Chandra, sir, from the Department of Hematology, SGPGIMS, Lucknow. That will be held next week. So thank you all the attendees, and thank you, ma'am and sir, for being with us for today.
Thank you, sir.
Thank
Thank you, ma'am.
you. Thank you.
Thank you, ma'am.
Thank you
Thank you so
all.
much.
Thank you all. Have a nice day.